So in the introductory video to cells and stress, I mentioned some cellular adaptations, and I'm going to go into them in a bit more detail now. So the first one is hypertrophy, which is common in non-dividing tissue and is often summarised as being due to overnourishment. So it is an increase in cell size, which then leads to an increase in the organ size, and is often due to an increase in workload, which induces growth factors. I'm sorry for my voice as well, I'm still dying. And as mentioned, it mainly occurs in tissue that's unable to divide, so the main example being myocardial hypertrophy. This is an increased growth of heart cells, the cardiomyocytes, often due to pressure or volume overload. The second type of adaptation is hyperplasia, which is often summarised as being overformation. This can be physiological or pathological and is due to an increase in cell number, which then leads to an increase in the organ size. It's in response to changes in hormones and growth factors, often caused by things like wounds or injuries. Because the cell number's increasing, it mainly occurs in tissues where division's high, such as the epidermis, the dermis, the liver, any sort of epithelial tissue. And it can also occur in tissues that contain stem cells, such as the bone marrow. So I mentioned that it can be both physiological and pathological. Some physiological examples of hyperplasia are hormonal, so an increase in cell number due to changes in the endometrium due to changes in increase in cell number due to changes in hormones. This can be seen in the endometrial cycle when the endometrium thickens, and also tissue development during puberty. There's also compensatory, which is an increase in cell number when sort of cells are removed to compensate for those which are removed. So, for example, when you get, if you have liver disease and you have part of your liver removed, it regrows. This is due to hyperplasia. But when the cell proliferation, so the cell number reaches sort of like the number that's needed, it's turned off by growth inhibitors. The third type of adaptation is atrophy, which is often summarised as being due to loss of nourishment. It's a decrease in cell size due to a loss of cell substance. The cells aren't dead, it's just that they've lost some of the function. This is often in response to a decrease of workload. So because of this, there's a reduced nervation, a reduced blood supply, reduced nutrition, reduced hormones, and reduced stimulation. A pathological example of this, which I'm going to go into detail a bit about, is SMA. SMA is caused by a mutation in the SMN1 gene, which encodes for the SMN protein. It's an autosomal recessive disease which is progressive and has fatal outcomes, and there are 4 different types. I'm not going to try and say the names because I'm going to debauch them, but they are wrote out in the table if you want to know what they are. So the first one is SMA1, which is infantile. It often occurs between the ages of 0 and 6 months, but can occur as early as like a couple of weeks old. The main symptom is described as floppy baby syndrome. So it's rapid motor neuron death, which results in degeneration and death of majorly bodily organs, specifically the respiratory system, which induces respiratory failure, and that's what causes most of the death. There's SMA2, which is an intermediate and has an onset of 6 to 18 months, but there's actually sort of no change in the life expectancy of this. It just occurs really early in life and affects them throughout life. So it's an intermediate form. These children are never able to stand and walk, but they are able to maintain a sitting position. Progression varies greatly, with some patients growing weaker over time, whilst others can avoid any sort of progression. The body muscles are weakened, and so the respiratory system is of major concern, but it's not, the life expectancy isn't severely reduced. The third type is SMA3, which is juvenile. This usually is noticed when the child's over the age of 1, but again results in a moderately normal life expectancy. Patients are usually able to walk without support for some time, although they may later lose the ability. But because of the strengthened muscles, there's less sort of concern over respiratory failure. And the final type is SMA4. It doesn't have a specific name, but is often referred to as late onset or adult SMA3. As you would assume, it occurs in the third decade of life during adulthood and is due to the gradual weakening of muscles, mainly the proximal muscles of the extremities, frequently resulting in people needing a wheelchair. Other complications are rare, so life expectancy is basically unaffected. The fourth type of cellular adaptation is metaplasia, which is basically summarised as new formation. So it's a change in the phenotype of already differentiated cells to form a completely new tissue type. It's often in response to chronic irritation. This change in phenotype is done to help so that the tissue is better adapted to withstand the stress. I'll go into an example in a bit. But at the same time as being able to better cope with one type of stress, it may reduce the function against different types of stresses and increases the risk of malignant transformations causing cancer. So the main example we were taught was about smoking. So there's metaplasia of the normal epithelium in the bronchi to squamous epithelium caused by the cigarette smoke. This is done because the squamous epithelium cells are better able to tolerate the toxic substances in cigarette smoke. However, an protective mechanism from the columnar epithelium is lost because these have the goblet and cilia cells. So there's no mucus to sort of trap any bacteria or nasties that are going down, and there's no cilia to clear the particles away, meaning you're more likely to get bacterial infections. So on one side, you're better able to cope with the smoking. On the downside, you're probably going to get a chest infection. And the final cellular adaptation that I'm going to talk about today is dysplasia. I am going to talk about this again in another video in the cancer section that I'm going to go on about. But this is a normal change in cellular shape, size and or organisation. It's very similar to the metaplasia, but it's abnormal. It occurs most frequently in hyperplastic squamous epithelium, but is also seen in the mucosa of the intestine. Dysplastic cells have significant potential to transform into cancerous cells and are usually regarded as pre-neoplastic lesions. Mild forms of dysplasia may be reversible as well if the cause of the change is removed. I also just wanted to include this image from my lecture slides. I couldn't be bothered copying and pasting it in mine, so enjoy my lecture slide. There you go. Hopefully I won't get sued, but yeah, it's a nice little summary diagram.